share my lecture. My topics is how to examine the rectal bilinear EUS. Rectal EUS, it produces high quality image because the waves are not passing through skin or muscle layer by traditional sonar. This high quality image produced by an EUS makes it ideal when very detailed images are required for examination or when a secondary procedure needs to be carried out. Who needs rectal endoscopic ultrasound? A rectal endoscopic ultrasound may be recommended to diagnose or treat gastrointestinal or digestive issue. It's useful produced for obtaining biopsy, tissue acquisition, or drainage cysts, or pelvic collection, or evaluating cancerous growth, or examine abnormalities. Transrectal endosonography is a safe imaging modality. We can do it without anesthesia. But before that, it's crucial to understand and know rectal pelvic anatomy actually. So we are going to spend 7 to 10 minutes knowing anatomy of inner canal and rectum. The rectum is the distal part of large gut, and it's a pelvic part of alimentary tract. It's located posterior part of the lesser pelvis in front of lower 3 pieces of sacrum and coccyx. It's begin as the recto-sigmoid junction at the level of 3 sacral vertebra, S3, S4, S5, and end as the anorectal junction 2-3 centimeter from and little below coccyx. It's measuring about 12 and 15 centimeter in length. The relation is important. Anterior relation to the male is urethra, prostate, seminal vesicle, and bladder, and rectovesical pouch with bowel loops. Posterior is sacrum and coccyx. Lateral relation for male or female is the same. Lateral upper third, الباراrectal fossa with bowel, والinternal iliac vessel والureter. الميدل third, البلفي rectal space والlevator ani muscle or pelvic floor muscle. اللور third, البلفي rectal space, levator ani muscle, and obturator internus muscle. For female, anterior, urethra, vagina, and uterus, pouch of Douglas, and uterovesical pouch, posterior, sacrum, and coccyx. For female, there is 2 pouch rather than male. We have rectovesical pouch and another pouch between uterus and the bladder. As I said, relation in the female, lateral relation is the same as male. Upper third, pararectal fossa, internal iliac vessel, and ureter, and we can add fallopian tube and ovary. In middle third, pelvic rectal space and levator ani. Lower third, pelvic rectal space, obturator internus, and levator ani muscle. Normal imaging of the rectal wall, as Dr. Ahmed Murad said, is the same. We have the 5-layer hyper, hypo, hyper, hypo, hyper. Hyper interface layer, الهايبو الماسكولاريس ميكوزا, الهايبر submucosa, and hypo muscularis propria. This muscularis propria, as Dr. Ahmed Murad said, we can subdivide it into inner circular and outer longitudinal. Why this is important? Because we can see the anal canal is a terminal part of the large intestine. Anal canal approximately 5 centimeters in length and extend from the anorectal junction to the anus, and it is located below the level of pelvic diaphragm in the perineum. Anal sphincter is very important in doing rectal EUS or anal EUS. The layer of anal sphincter from inside out are internal alien sphincter, intersphincteric area, and external alien sphincter. Internal alien sphincter is a downward continuation of the inner circular layer of muscularis propria of the rectal wall. And the cervical muscle in the sphincter region are thicker than those of rectal circular muscle. Intersphincteric area is a fat containing space, which lies outside the internal inner sphincter. The external inner sphincter, it's about 2 and 3 millimeter, and intersphincteric area is about 1 millimeter. The whole length is about 4 millimeter. And the intersphincteric area is a downward continuation of outer longitudinal fibroelastic layer of the longitudinal muscular layer of the rectal wall. The longitudinal fibroelastic layer, this layer continue into external anal sphincter, goes through internal anal sphincter, and it can be seen by EUS as an alternating line of black and white. And external anal sphincter consistent of 3 loops. We have 3 loops. The first part is subcutaneous loop, superficial loop, and deep loop. The superficial loop is surrounding the lower part of internal anal sphincter. A deep loop surrounding the upper part of internal anal sphincter. And it may be confused with puborectalis muscle as it merges together. So, what is the final arrangement? Fiber from internal and external anal sphincter. From inside and outside, internal anal sphincter, intersphincteric area, external anal sphincter. From below to upward, subcutaneous loop, superficial loop, and deep loop. Relation of the anal canal, الانوكوكسجين رافي and the anal canal divided the anal triangle into 2 smaller triangles called ischianal fossa. This ischianal fossa is a fat containing space below the pelvic of the diaphragm. How to do rectal EUS? First, position of the patient. As Dr. Ahmed Murad said, the rectal endoscopic ultrasound can do with patient in left lateral, lysotomy position. It depends on examiner preference. Ahmed Murad said rule of water, but we are not required for water in anal examination, but we have to use it in evaluation of rectal wall. Water remain independent part. We use approximately about 100-200 millimeter of water, and we can explain for the patient to retain his water inside him. So we are recommended using this maneuver when the patient is slightly conscious. Air is the enemy of endoscopic ultrasound. Must be air insufficient should be kept to a minimum to provide visualization of the lumen during movement and to reach a position. Reaching the rectosigmoid may be need only small amount of air. The position, I will share the Dr. Malay Sharma tips and tricks using rectal ultrasound. We are using the same position of doing a basing colonoscopy, and the movement is in and out movement, and right clockwise or left anti-clockwise rotation. We are rarely using up and down knobs, but before that, we can do some sort of external orientation. What's the mean of external orientation? This is the echo endoscope. Consider this bottle as a patient. This is the head, and this is the leg, and he is in left lateral position. So this echo endoscope facing anterior to the patient. If I rotate this 180 degree, so I will become posterior. 90 degree above, here will be left lateral. In the same way, or opposite way, will be right lateral. And I can put a band here and do my external navigator to the position of echo endoscope. So the proper position, combination of free movement, in and out, rotation, left and right, up and down. But it's rare to use up and down, and the left-right movement is not commonly required in anal ultrasound. Station, I have a 4 station for diagnosis of anorectal ultrasound. Anal part, it's about 5 centimeter in distance. Station 2, lower rectum, 5 to 10. Station 3, 10 to 15. Station 4, 15 to 20. So the ideal or what requested for you is 20 centimeter. It is enough? No. You have to pass, if you can, rectus sigmoid. So you have to trace the tracing of aorta. Imaging from sigmoid colon may take the imaging beam up to L3 vertebra. So you have to pass the rectus sigmoid to get IVC aorta. And this is left kidney. So I have to, my first position, I have to pass rectus sigmoid. My landmark is identified IVC and aorta. So I will back scope smoothly and slightly backdraw the echo endoscope. This is IVC, this is aorta. Back, 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 back. Here start division of aorta IVC to common iliac vessel. Start, back, back, back. Sorry. Yes. This is a division of common iliac to external and internal iliac vessel. It is not simply to identify which artery or vein. You have to put your pulse Doppler, but there is a basic rule. Artery are always near echo endoscope, but both are each together. Artery beside the vein. An artery is much closer to the echo endoscope. Why I do this? Because recently we can do hypogastric plexus neurolysis for pelvic tumor. So I have to identify common iliac division from artery to identify hypogastric plexus. Another reason, and this is a simple case of pelvic tumor, and easily identify malignant lymph node parailiac. And this is presence of malignant node parailiac or iliac vessel lymph node. It is a sure sign of malignancy and change your decision for the surgery. And complete withdrawal echo endoscope anteriorly. I do my external navigator. Aorta IVC is located posteriorly. So when I might change clockwise or anti-clockwise rotation to put my landmark anterior, so I found this large anechoic structure. It is the urinary bladder. Urinary bladder has a 4 surface: superior surface, posterolateral surface, and inferolateral surface. And it is triangular in shape. Located inferiorly, here the prostate. The prostate is an conical shape. This is conical shape located base and apex. And this is base located to the neck of the bladder. And prostate have an important structure located posterolateral to it is a seminal vesicle. And don't be hurry to consider as as a malignant lymph node, you have to take your time because we always start before mimic this structure as a malignant lymph node, but we considered it as a seminal vesicle. Also, you can easily identify the anechoic structure inside the prostate is a urestratic or urethra part of the prostate. Prostatic urethra. And the blood vessel near to the prostate is a pudendal artery and pudendal vein. In the female, you can easily identify this is a bladder, and you can easily identify the vagina due to presence of air inside the vagina. And this is a urethra or female urethra. Back to the last part of examination of the anal canal. Once you found the prostate is anatomically just near the ano-rectal junction. If I can found this, I can found an important landmark, which is waterfall sign or downward continuation of fourth layer here, muscular layer, giving a picture of rectal ampulla. And this is rectal ampulla. This is a waterfall sign or downward continuation of muscle layer of the rectum. You can see here, this is a downward continuation of first layer is thin, became here much more thicker than normal fourth layer. So this is anorectal junction. This is continuation is the internal anal sphincter. This is internal anal sphincter. The outward to it is intersphincterate area. And this is intersphincterate area, as we said, alternation black and white, white and black, black and white. Internal anal sphincter covered by external anal sphincter, the deep part, superficial part by external anal sphincter. If I can't find this ampulla or prostate, there is an important landmark. This hyperechoic strand is the puborectalis muscle. You can show this is the ampulla of the rectum, internal anal sphincter, intersphincterate area, external anal sphincter. You can show here this at the end of internal anal sphincter. So the subcutaneous part of the anal canal or the lower third of the anal canal is totally surrounded by external anal sphincter only. There is no internal anal sphincter at the last or lower third of external anal canal. Why we do this? Because application in the perianal fistula, I have to distinguish between intersphincteric part or transsphincteric anal fistula, suprasphincteric or extrasphincteric. I have to tell the surgeon which type of perianal fistula I saw. At the last, our Prophet Muhammad said, Allah does not thank the person who does not thank people. I have to thank Professor Malay Sharma, consultant gastroenterology and hepatology, Aryavat Hospital, Meerut, India, and my friend is Piyush Sumani for their great support and help. And of course, my old brother and who always support me, Professor Hukuna Akasha, Professor of Internal Medicine, Qasr Al Aina University. And thank you for your attention.